All right, Dr. Bockow, uh, thank you for joining me on the Jaw Hacks channel for an interview today. We appreciate having you.
I'm so happy to be here. Thanks for having me.
I'm going to introduce you briefly and then we'll jump right into the questions. Dr. Rebecca Bockow is a dual-trained orthodontist and periodontist, the only dual-trained provider in Seattle and one of only a handful in the country. She grew up in the greater Seattle area and attended university prep for high school. She received a BS in biology with honors at Haverford College, where she also played soccer, squash, tennis, and ran cross country and track. She completed her DDS at the University of Washington Dental School in 2007. Dr. Bockow practiced as a general dentist in Seattle for 2 years while simultaneously teaching at the University of Washington Dental School. She completed a highly selective dual specialty program combining orthodontics and periodontics at the University of Pennsylvania. She is a board certified orthodontist and periodontist. While simultaneously enrolled in 2 residency programs, she also received a master's in oral biology. Dr. Bockow lectures nationally on periodontics, orthodontics, interdisciplinary orthodontics, airway, and skeletal growth and development. She contributes to multiple professional journals as an author and editor. Dr. Bockow is also a resident faculty at Spear Education. So welcome. And actually, I hadn't heard of Spear Education until I looked you up, and Spear Education is really cool. I
It
was
is really
familiar
cool.
with this idea of continuing ed, dental sort of schools, and the few that I'm aware of, unfortunately, like LVI and FBI, I have negative associations with because they're the ones who promote some of these tooth-borne expanders that have damaged me and some of the other people that I'm in touch with. But I was watching some of Spear's stuff yesterday, and it is very cool.
It is. It's really exciting to be a part of it. You know, you talk about continuing education, and it's a very forward-thinking organization that's really thinking about the putting the patient first and really being science-oriented.
I thought to myself that if I had gone down the road of becoming a dentist, that I would definitely want to be part of the Spear world at some point.
Yeah, it's a great group to be a part of for sure.
Cool, cool. So, what I didn't mention in the introduction is that you are a provider of both the MSE appliance as well as another type of adult expansion technique called SFOT that I've spoken about on my channel. And in this interview, I'm going to ask you a question or two about combining those and comparing and contrasting those. Could you start by please just briefly describing the MSE technique and the appliance as well as the SFOT?
Sure. Well, maybe I can back up a little bit. So when we think about airway, and maybe the listeners know this already, but when we think about sleep quality, we think about airway. When we think about airway, anatomically, we have nasal passages, and then we have a big tube. So right back here, we have the adenoids, and then the soft palate, and then the base of the tongue and the tonsils. And so anywhere along this pathway, we can have some sort of blockage. And so when we think about creating a bigger box, so to speak, when we want to improve airway, we have to think about those targeted areas. And so the two main ways we influence in dentistry is we can go wider and we can come forward. And by going wider, we make more space for nasal breathing, and we make more room for the tongue volumetrically, and coming forward, we make more room for the tongue because it comes out of the back of the throat. So with that in mind, all of our strategies will include those sorts of movements. So then we have to back up and we look at each individual patient, and we have to ask, based on the patient in front of us, what's the best solution for those two movements? And so when we think about MSE, it becomes really powerful, incredibly powerful, because we're widening the suture. which means we're keeping the teeth in the bone, and we're moving the bone itself. So we're protecting the integrity of the periodontal complex, we're protecting the integrity of the tooth in the bone, but as we open the suture, we open the nasal passages. So we immediately improve nasal breathing, and maybe you experienced that yourself. But we're also creating volumetric space for the tongue. SFOT is a little different because we're not influencing the suture. We're doing what I would call dental-alveolar tipping. So we are creating more space for the tongue, but we're not influencing the suture itself. So it's powerful, it's a useful tool, but it's on a spectrum. If jaw surgery is here, MSE would be here, SFOT would be here, doing nothing would be over here. So it's part of a continuum. Now, I think, Ronnie, you were asking, when could you combine it? There would be two instances where you could combine SFOT and MSE that I can think of. One would be if in the process of MSE, you run the risk of damaging the periodontium on the first molars. That's a risk. So we could do some bone augmentation where the MSE is attached. The other instance would be if you really want to go wide on the top. We've done it before where we do it on the bottom. And I've shared a case with Casey Lee down in California who does the ease procedure. And so we did lower SFOT, upper ease, and then we ultimately ended up doing an MMA surgery to get both jaws forward because that only addresses the width.
Understood. So how common is it for you to have to augment an MSE expansion with something like SFOT on the lower? When I asked Dr. Ting that question, he said it was pretty rare and that most people were deficient up top. So what's your experience with that?
It's very rare. I haven't done it in probably 2 years.
Okay. And would it be the kind of thing where if you had a patient who came to you looking for the MSE, looking to maximize their maxillary transverse expansion, would that be something you would be open to kind of over expanding them on the top for their because they wanted to, and then following up with the procedure on the lower?
It's definitely possible. Um, I have a patient right now that we're widening because we're trying to make room to accommodate her natural volume of her tongue. And so as we look at that cave hold, for example, trying to make sure that the maxilla can accommodate the tongue as the tongue rests in the roof of the mouth.
Sure.
So we're widening, but I also want to say we have a limit in terms of how wide we can go because of the succenator muscle. So even if we widen because of this muscle, it may come back a little bit. So we do have some limits. We can't just keep going.
Understood. Could you please just explain the physiology of that limit in a little bit more detail?
Sure, we have a muscle attachment right here. This muscle, the muscle that allows us to open, well, it's our matter muscle here. And then we have some internal muscles as well. They are what they are. And so even if you expand, eventually, sometimes those muscles will bring everything back together.
So it's a matter of stability and not a matter of like an acute sensation of like pain or something that tells you, okay, we have to stop expanding now.
No one will have pain. It'll just be more about, yeah, long-term stability. We have to create an equilibrium. So we want even cheek pressure and tongue pressure. So cheeks from the outside, tongue from the inside.
Right. The other question I had about combining MSE and SFOT is MSE, of course, is known as a transverse expander. A lot of the people I talk to are not exclusively concerned with airway. They're essentially looking to improve their aesthetics, and they perceive themselves to be deficient in this from the side profile. They tell me, you know, sure, MSE sounds great. I'd love to have a bigger, brighter smile. I'd love to maybe expand my cheekbones a little bit, and I'll ask you about that in a second. But then they say, but what the heck is MSE going to do for me in the forward direction? What do you think about combining MSE and SFOT to help bring teeth forward
Good question. We can do it a little bit, but not a ton. So in practice, we do a lot of jaw surgery as well. And we get a lot of consultations. People say, well, I'm excited about MSC. And then in the conversation, sort of as we continue the conversation, we realize truly that they're deficient in the AP or the forward back. And then it really becomes a conversation about jaw surgery. I really want to tell your listeners too, jaw surgery is not a bad thing. It's a very powerful thing, and if done by the right team, can be a phenomenal treatment plan for patients. So I think people are nervous about pursuing that option, but it really can be a great option.
So, do you think then that the hype around the downsides of jaw surgery are kind of overblown? Does it have a stigma that it might not deserve?
It's possible. Um, I don't know what's out there. I can tell you in our practice, our jaw surgery patients are our biggest fans. They they come in, they can't breathe well, or they're unhappy with their aesthetics. Some of them they can't close their lips together because jaws have grown long. And so as we do the surgery and bring that lower jaw forward, all of a sudden they can close their lips comfortably, breathe easily through their nose. Routinely, we hear from our patients. They say, Dr. Bockow, I woke up from the surgery. I was so swollen. I was in the hospital, and I knew immediately that I could breathe better. So, I mean, without knocking on something, I haven't had a patient yet who regretted doing surgery.
Do you credit a lot of that to the surgeon that you work with and your probably tremendous amount of trust that you have in that person? And maybe you could tell us who that is.
So there's a few things that have to go into a good surgical outcome. One is an understanding of where the teeth need to go pre-surgically. There's a lot of pre-surgical orthodontics that has to happen. And then you have to have a surgeon that understands aesthetics and airway and function. Because at the end of the surgery, we make sure lips can come together in a relaxed way, that there's room for the tongue, and that breathing is good, and that ultimately the teeth can fit together. So all of those things have to happen. We're very lucky in Seattle. We have great surgeons here. There's a number of people I trust in Seattle, and then my favorite person in the whole wide world of surgery is Michael Gunson down in Santa Barbara.
Do you have patients who come to you primarily interested in sort of rebuilding their face for aesthetic reasons? And do you feel comfortable recommending those patients for MSC and double jaw surgery? Or do you require some sort of airway deficiency and documented breathing troubles before you'll put someone through those kinds of procedures?
I think the answer is both. So I think when I facial aesthetics tends to pattern with health. And so oftentimes the patients that are unhappy with their aesthetic have some degree of airway complaint or TMJ problems, or there's usually a breakdown somewhere. That's not always true. So but in general, there's some complaint somewhere along the line. But certainly we can do surgery for aesthetics. We can do surgery for airway. We can do surgery for a number of reasons.
Got it. So back to the SFOT, since there's only so many people in the world who I can actually talk to about that procedure, how much expansion can that procedure by itself actually achieve in the transverse and in the forward direction?
Great question. I wish I had a prop. So if we think the maxilla is almost a funnel shape. The teeth kind of go around this funnel. And so if we think about SFOT, we're adding bone to the outside of the tooth, and then orthodontically, we're moving the teeth. And so the roots themselves are not moving, and we're not translating the tooth. It's glorified tipping, to be honest. So we sort of come like this. And so we can get maybe 2 millimeters in any direction, I think, predictably.
Wow, that's really not much.
No, and that's why it has fallen off in terms of what we use compared to something like MSE. MSE, we're fixing cross bites. We're getting, 10 plus millimeters of expansion. We're changing jaws in a way that we can't with SFOT.
And why can you only tip teeth with even with SFOT? Why aren't you able to actually translate the tooth through the new bone that you've placed?
It doesn't stay. It doesn't stay in the thickness that you would want. So if we want apex to translate, I've seen some case reports where they've actually seen root resorption long term.
Hmm.
And then once you have pre-existing recession, it becomes even less predictable. Because let's say you have someone with a thin alveolar plate and there's barely any bone covering the tooth, and then you graft it and then you push, it's just not stable. It's not long lasting.
Hmm. Gosh, you're totally bursting the SFOT bubble right now.
I'm sorry. And I'll tell you, I used to lecture on this all over the country. It still has a place, but I think it's not a panacea.
And what is its place in your opinion?
I think it's good for augmenting, and I think it's good for small movements. So even myself, so I have what we would call a deep mental labial fold. So there's a bit of a curl right here. Um, in the patients I've treated that maybe it's like this or even more accentuated, when we release that muscle insertion and put bone graft here, in the patients we've treated, it gives a lift and a softening here. So almost like a cosmetic procedure. It can be very powerful, for example, in the lower incisor region when we're trying to get the lower teeth forward a little bit. In a patient that's truly mandibular deficient, we can get some added width. It does have a place. It's just not going to take the place of MSC or surgery.
Right. So it's a far better option than doing a tooth-borne expander without putting in that little bit of extra bone and softening up the teeth a little bit with the corticotomies. But
For sure.
that's essentially what it is. It's glorified tooth-borne expansion.
Yep. Yep.
I, I've often said to people who are interested in doing the AGGA appliance, are you familiar with the AGGA appliance?
Unfortunately, yes, but not because of positive patient responses.
Sure. Well, what I was going to say before I ask you, what I was going to say is my understanding of that appliance is that it's essentially just putting mechanical force on the structures of the front of the maxilla, maybe a little bit of the bone, maybe the teeth, maybe a little bit of both. And then those teeth are coming forward through the alveolar bone, just like you document in your article. So what I was thinking is, why would you want to push the teeth forward through the bone? If you're going to do that, you could at least add a little bit of bone there before you do the pushing, and that would at least make it safer. So in no way could the AGGA be superior to something like SFOT.
Your thought process is more sophisticated than people that are doing treatment in my region. So I applaud you. I'm impressed with yes. I think when we augment the bone, it can make the situation a little safer. But I think that the uh, I don't think that the AGGA appliance is ever going to bring the whole maxilla forward, even though that's what it claims to do. I think it's pushing the teeth out of the bone.
Right, right. And if you would feel comfortable answering, and I know this kind of drags you into the mud a little bit with the gossip, but do you think there's any credibility to the claim that the way the AGGA works is by pressing on the nasopalatine nerve and triggering some kind of organic bone growth? No,
No,
right? It's
it
total
doesn't work.
nonsense, right?
It doesn't work. No. I think
Okay.
you think if we want to be honest, we have to look back to skeletal growth and development. So you know, Ronnie, a lot of my interest is looking at little kids. So if we take a huge step backwards and we look at breastfeeding babies, breastfeeding is where that starts. You have a child that's bringing their tongue up into the part of the mouth, and the tongue pushing into the alveolar housing is what shapes the growth of the upper jaw and the width, and it's what brings the premaxilla forward. The baby working at the breast is what gets the lower jaw to come forward, and those movements start to kick off the growth and development not only of the masseter and the lower jaw, but also the midface and the nasal passages. And that's the first time when we can identify whether or not a child is tongue-tied. Then you think about nasal breathing, lips together, the foods we eat as we grow, the first 1,000 days of life. This is what starts to grow and develop the jaws. If you have a child that's breathing with their mouth open, tongue posture is low, maybe adenoids and tonsils get larger, and you start to get this inward pressure from the cheeks. The mouth goes like this, then that starts to look like crowding. Then the lower jaw drops down and back. The maxilla might come down. Now we have our gummy smile patient or our open bite patient or our deficient patients. And so it has to do with the way the jaws grew. They grew in a downward backward trajectory that manifests as crowding. So when they get to the orthodontist at 12 or 13, they say, oh, you have crowding. The true answer is that their jaws are underdeveloped. They had a breathing issue long before anyone took out teeth. So to put in a tooth-borne appliance like an AGGA or a Crozet or a DNA appliance or an Alpha appliance or any of these appliances, and to try to push the teeth is not really what's happening. We need to grow the bone itself. And so we need to look at the sutures. And that's why MSE becomes important. Now, if we catch these kids early, like 6, 7, 8 and younger, then we can start to grow the jaws. But we have to start really young,
Right.
to use tooth-borne appliances.
Right. It sounds like what you just described are environmental causes of malocclusion. Uh, you probably know Dr. Mike Mew and Dr. John Mew have essentially been uh, gotten in a lot of trouble in the British dental world for claiming that there was a cause for malocclusion other than purely genetics. Have we gotten to a point where we understand, at a scientific level in sort of scientifically rigid ways that there are environmental causes for malocclusion and crowding?
So I think we have that documentation in our orthodontic literature that goes back many, many, many years. So I don't know that anyone has ever argued with the Mews on that point. Um, there's documentation about, for example, there's a term in the orthodontic literature that they call adenoid faces, where if you have a patient that has large adenoids, it changes the way the jaws grow and develop. There were studies in the 60s where they blocked the nasal passages of primates and they watched their faces change. And that's all published in orthodontic literature. They watched a crossbite develop and narrow arches and crowding in 6 months. So I think there's a consensus that the way we breathe and what we eat and environmental factors can change the way the jaws grow.
I see. And just a kind of a personal question. I have a niece now. She's going to be 2 in about next month. She's going to be 2 years old. What advice do you give to parents with little children to encourage the best environmental stimuli to develop good faces?
Great question. So looking at breathing habits, looking at habits in general. So taking away pacifiers early, stopping digit sucking or what we call non-nutritive sucking early, helping make sure that that tongue is coming up in forward. So looking for things like tongue ties, making sure that food choices are hard, crunchy foods instead of soft, pureed foods. If tonsils and adenoids are an issue, getting them out early, getting kids regular cups instead of sippy cups early. All of these things, it's really the tongue and the way we breathe that influence jaw growth in those early years. If you start to see issues in little kids, my kids are 2 and 4, and they're using Myo Munchies every night. which helps stimulate the muscles and gets those jaws working. That's a great tool. Slightly older kids, you can look at things like a myo brace or healthy start. Those sorts of things are great at molding and shaping this and helping with habit correction.
Great. And what do you think of the idea that breastfeeding is super important for children getting their tongue up onto the roof of the mouth? Is there any legitimacy to that?
100%, 100%. So for the baby to empty the breast, the tongue has to come forward, the anterior portion of the tongue, and the dorsum. So that's we may have heard things like an anterior tongue tie, posterior tongue tie. So the anterior tongue tie, that's the front part of the tongue, but the dorsum is the posterior part of the tongue. And both movements have to happen in order to empty the breast, but also to shape the palate. And it's almost every day that I see kids that have underdeveloped upper jaws, and very often, not always, but very often they have some degree of tongue tie.
Hmm. So the AGGA providers very often recommend tongue tie releases along with the appliance. And wrote to me recently with a horror story about a tongue tie release. And then they speculated, I'm starting to think that all this tongue tie, lip tie release stuff is just part of the bull crap kind of treatment package. So would you say that you don't want to throw the baby out with the bathwater? We want to keep the tongue tie releases and just ditch the appliance. So you do think tongue tie releases are very important?
I'll back up. The function, so I think about structure, function, and behavior. And so in orthodontics, that we're the structure people. So we're looking at the bones themselves. Function is whether or not the patient can move their tongue in the right way. And then behavior being, what do we do with it once we can move it? And this is not my I the person I heard these three terms from was Barry Raphael. So this is not my original thought, but I just love it. So I'm going to borrow it. But so the little more conservative, Ronnie, I look at the patient's ability to move their tongue. So what we do is our order, we expand first, and then we send the patient for myofunctional therapy. There's many instances where a patient can, with flexibility, with good training, with muscle tonicity, they're able to move their tongue in all the ways that we need them to move their tongue, and they don't need a release. So we start with myofunctional therapy. If after they work with the therapist says, you know what, you got to here, with a release, you could get to here, only then would we consider a release. So the release becomes the last step, and we only do it to increase function. We don't do it just to do it.
I understand. I understand. So it's not because my understanding and actually my experience with the general dentists doing the tooth-borne ortho appliances is that the tongue tie release recommendation comes like right up front. Usually it's like a package deal. It's like when you're buying a car and they ask you if you want all the upgrades. It kind of comes like that. So you're suggesting a more nuanced, individualized approach to diagnosing and correcting tongue ties.
Yes, not everybody needs a tongue tie release. Um, I don't know if your listeners have heard about the Health Latch Circle, but this is something, and you might be interested in this as well. But there's a phenomenal, very forward thinking dentist in Seattle. His name's Dr. James Thomas. And he said, there's a lot of providers out there, and we need one place to go to know who's credible and who to see in our area, and what sort of training if they had, and is this a good person to see in this world of airway tongue tie release myofunctional therapy? I think of it almost like LinkedIn for this whole world. And so he's creating it. He's already taken it online, and it's supposed to be for the layperson to be able to navigate all these questions. Like, okay, who do I go see, and is this person credible? What sort of educational background do they have?
What's the link, please? One more time.
Health Latch Circle.
Health Latch Circle. Okay, so people can probably just Google that and figure it out, and I'll try to drop a link in the description below. So I want to circle back to James Nestor's new book, Breath. I'm not sure if you've had a chance to read it, but maybe you know about it.
For sure, I thought it was great.
I'm enjoying it as well. I haven't finished it, but I saw an interview he did with Joe Rogan, and so I made a post about this book, and immediately got hit in the comment section. Ronnie, how the heck can you recommend this book when this guy is recommending Homeoblock as a solution for expanding in adults? So then I had to make a response to that. So could you ever see yourself prescribing a Homeoblock instead of an MSE, or are they is one just better than the other, objectively
Um,
speaking?
that was the only part of the book that I disagreed with. So um, I don't think there's a lot of science or proof behind that. If you look at people that do Homeo blocks, I to date haven't seen anyone post before and after sleep study correlating with the before and after CBCT and really looking at volumetric changes in the bone and moving the bone in a significant way. I mean, they show little minor movements, but why not just do a TAT expander? Why not do surgery? If you're suffering from sleep apnea or you're not breathing well, it's it's 18 month treatment plan. It's not a long, 2-year treatment plan, and we've changed somebody's breathing and jaw position for the rest of their life. So I would do something that's more has more scientific backing.
Right. And while we're on this subject, you sent me an article. And in that article, there was a lot of discussion of tooth-borne versus bone-borne appliances, or what you call orthopedic versus orthodontic appliances. Could you just summarize your conclusions from that article about what appliances an adult should consider when trying to expand?
Sure, for sure. Well, we have to think about sutural biology. So the maxilla, it looks like a church spire. And so as we expand that upper jaw, we want to influence the suture itself. Can I share a slide?
Yes, go ahead and try, and in the meantime, I'll make sure you have permission to screen share. Oh, good.
Okay. So so if we take a cross section, so a 1-year-old male, that suture is pretty much open. 10-year-old male, the suture is more intertwined. 12-and-a-half-year-old female. So now we get into menses, that suture becomes more and more intertwined. And so as we think about a tooth-borne appliance, if if you use a tooth-borne appliance and you push on the maxilla, the path of least the area with the least resistance will move. And so as that suture becomes more intertwined, you get more tooth tipping and less bony changes. So I'm going to show you, this was a study published in 2007, looking at a 10-year-old male and a 16-year-old male. These are both tooth-borne appliances. And so, of course, in the 10-year-old male, that suture is not fully intertwined. We don't think it truly fuses. So thinking about airway, in a 10-year-old, no problem. We're opening up that suture, we're improving nasal breathing. If you look at with the 16-year-old, look at that suture, it becomes very, very jagged, and we don't see that same split as we move to posteriorly. Now, if somebody's not taking a CBCT after expansion, they may think that these two patients are equivalent because clinically they both have a diastema, they both have the gap between their front two teeth. But from a true airway and a stability perspective, the impact on the bone is very different. And so now here, if you look at this image, now what's interesting, look at the 16-year-old male. Do you see how they started to have a deviated septum? A deviated septum is highly correlated with the narrow maxilla. And so as we expand that 10-year-old male, no problem, we opened the suture, we influenced nasal passages. But look at the 16-year-old. Do we really think he felt the difference? in his nasal breathing. So if our true goal is just to get some dental alveolar widening, then we did it here. But if it's truly to open up nasal passages, influence sleep, and have good stability long term, we want to think about bone-borne appliances.
Doctor, if I
And
could
so,
interrupt. So,
yeah,
so the 16-year-old here has been treated with a tooth-borne expander.
yep, these are both Hyrax expanders.
And the,
So in
how
a
what how does the
child,
high rance base basically work? Can you just describe it
it's
briefly?
glued to the upper molars, and you turn it once or twice, about once a day, each turn 1/4 millimeter. So that would be considered an orthopedic appliance. So that's much stronger than like a Crozat or a DNA or an Alpha appliance. This will be much stronger. And so even in the strongest appliances we have, once you get up into the teenage years, you're not going to see the same influence on the suture. And so then let me show you what MSE ends up looking like. So here's MSE. So what I've highlighted here is the TADs through the maxillary bone, and I put 2 pink lines there to show how much that suture opens. Now, I know you're not trained as a dentist or a radiologist, but I think we all can see the changes in the nasal patches. So if we look up around the turbinates, that's a huge opening. That patient can definitely breathe.
Wow.
And these are quick. And so here this is looking at the maxilla. We see this huge parallel opening. This is an adult. So we looked at a 16-year-old before, now we're looking at adult. So we're really open the suture here, and then you can see what that looks like. So you asked about changes in cheekbones. So if we look at these before and after pictures, we do thickening of the midface. It's subtle, but we see it. And so you can see that in these 2 before and after pictures.
And do you feel like you can see it with your eye as well in your patients, a change in the midface?
It's very subtle. It's subtle, but it's there. Because if critically here, you can even see changes up into the bridge of the nose in these pictures.
Hmm.
So it's all the way up into here, and it's this whole complex.
Hmm.
So the sutures are here.
Right.
Let me see. And so you can see here, bone-borne versus tooth-borne, we're getting a more parallel opening compared to more tipping. And so, I can show you patient examples, but let me see, we'll look at some before and afters. So this is MSE. This is MSE without any SFOT, and we're not seeing dental tipping. We're seeing those teeth are straight up and down.
Hmm. Hmm.
So really making space for them.
Hmm. And can you just comment on the importance of the teeth being upright in the bone versus being tilted?
Sure. So if you have dental tipping, you're going to get a lot of recession. Here, I'll show these as well. So when we have dental tipping, it's very unstable because they can tip back, and you can get a lot of secondary recession. So this was an interesting paper. Let me make sure I throw up the citation. If I don't have it here, I can send it to you.
Sure.
Here we go. Lee et al. 2002. And this is called a finite element analysis. So this is all computer modeling, but they release 4 different expander designs. So A would be the MSE, but it's not connected to the teeth. B is the acrylic design TAD expander. C is similar to SE, and then D would be your regular tooth-borne appliance. And so if we look at those colored images, A and C are really where you see the true changes in the suture. So because the TADs are parallel to the mid-palatal suture, you get the most influence at the sutural level. B, you get less influence at the suture. And then D, of course, you get more influence at the teeth itself. And I think this model was based on the density of an adult, not a child.
Mhm. So
And
this is
then
all to
looking,
say, uh, this
oh,
is
go
all to
ahead.
say, this is all to say that the MSE is your appliance of choice, and the data seems to suggest that it's the most effective in achieving the suture split and the airway expansion that's so desired.
Yes. So if we look, for example, at A versus D, A, we have TADs and those would be the two extremes here. So A is complete sutural changes, no dental changes, whereas D, you get a lot of pressure on the teeth with very little pressure at the suture. So, so D is what's happening with a tooth-borne appliance in an adult.
Right, right. So D is James Nestor in his Homeoblock, and A is the MSE, obviously a superior choice for an adult.
I would think so.
And
Um,
what do you have to say about like the DNA provider and the Homeoblock provider claims that their devices are having some, what's the word? What are the words they use? They call it like a special effect on the maxilla or on the teeth. Is there really something else going on other than just brute force being applied to the teeth and to the maybe a little bit to the roof of the mouth?
I think what's happening is dental alveolar bending and some reshaping. And I can get out of this if you'd like here.
Well, if you
Um,
have anything else you'd like to show, you can get back to it if you'd like at some point a little bit
um,
later.
I mean, I've got plenty of stuff to share depending on what you want to see. Um,
Could you tell us a little bit about this idea of bone bending? People probably don't think of bone being able to bend, like you don't think of a ceramic plate being able to bend, but what's that all about?
so I think I'm sure people have seen online some before and after pictures with DNA, Homeoblock, a lot of these, and they're just sort of bending the bone. So it's similar to what we're getting with SFOT. We can make things look nice. We can get to some extent some dental alveolar widening with some of these appliances, but it's just tipping. I think we just have to be honest with what we're achieving. So the stability is called into question.
Right, right. Um, Another thing I wanted to ask you about is surgical assist for MSE and if you see a role for that in your practice.
Sure, well, I can address that easily too. When I first started getting into working with the MSE appliance, we had a lot of failures with the nails. Um, and the failure meaning that we turned the appliance and either we saw a very small sutural opening or we saw the appliance just get embedded into the tissue. And so we started incorporating what Stanley Liu and Audrey Yuen have coined the dome procedure,
Mhm.
distraction osteogenesis maxillary expansion. And we're seeing a really nice opening of that mid-palatal suture with the dome procedure. I know Casey Lee down in California, Dr. Casey Lee does what he calls the ease procedure, which is very similar to dome, except it has an endoscopic access, and that can also work very well. So for adult males, we're using surgical intervention. It's minor, but it's still a surgery.
So on most of your male patients, you recommend some kind of surgical assist?
I do.
You don't fuss around with the cortical puncturing or anything like that?
You know, Dr. Ting does it and he does it really well. And so I haven't tried it. I can't really speak to that. Um, I know you've had him on here. So if he says it works in his hands, that's amazing. So I would trust him 100%. He's a very smart clinician
He is. He's a good man. And
for sure.
but what do you think about surgical assist preventing cheekbone expansion because you're essentially cutting off the force lever, right?
Oh, sure. That'll work. That'll work. Absolutely.
So
I might
then,
have a picture of that. Do you want to see a picture of that?
yeah, I do.
Give me just a sec here. I just wanted to show this. So there's the cuts right there.
Oh, wow, look at that.
So you see a nice opening up into the nasal passage, a nice palatal split, um, but we're not seeing changes in the cheekbone.
So then for your male patients, they're basically SOL when it comes to mid-face expansion if they're getting surgical assists, right?
And I can't say that's been a big chief complaint for us. Um, I haven't really heard that as a big chief complaint for a lot of our patients. A lot of them want a wider smile, and we're certainly able to achieve that.
Right. I think it's a bias from my end because not most, half of the people who I talk to are interested, I would say 75% in aesthetic rebuilding. And so they see the MSE's chief appeal as the ability to make their midface look a little bit more manly or a little bit more developed, a little bit more pronounced. And so the idea of getting rid of that benefit is like a deal breaker.
I think you're still going to get that wide smile. Um, it's not as noticeable as you think in either direction.
Hmm.
There's and they're still going to get the added benefit of breathing. I can't say it hasn't been a negative sequela.
Hmm. Hmm. Yeah, probably. I think a lot of it is maybe my fault because I've documented my MSE case, and I think these are, by the way, these aren't my conclusions. These are the conclusions that my viewers drew from viewing my pictures. They see that my cheekbones, or at least one of my cheekbones, my left cheekbone, changed a lot with MSE. And so in my interview with Dr. Ting and Dr. Vaughn, when they said, or well, when Dr. Vaughn said that he didn't think midface expansion was, um, well, he basically said he didn't think it happened with MSE at all. I got some crap in my comments because I didn't push back and say, well, my midface expanded. So I think people are looking at my pictures and thinking, okay, well, I want that for me. But if you actually look at my case, I did not have a surgical assist, and I had, I believe, a pretty asymmetric expansion. I think most of it happened on the left side. Um, and so I tell people, look, like, sure, you can not do the surgical assist, but comes with risk. And I pretty much experienced some of the worst of that risk by getting this asymmetric expansion that left me with a terrible bite for months after I did the MSE. Like it was like all on the left side, the expansion. I think I got like 9 or 10 millimeters, and my rough estimate is that 7 went to the left and maybe 3 went to the right. So while we're on that subject, do you think asymmetric splitting is common with MSE, or do you think my experience was a fluke, or do you think that I'm even misinterpreting what happened to me and that I probably didn't even have an asymmetry at the level of the bone?
Such a good question. I think you probably did. Um, Juan Moon, who would be another person for you to have on your show, or your channel. So he and his residents published that almost every case is asymmetrical in its expansion. Um, some you see it more than others. In my practice, I've had 2 cases go asymmetrical, and we actually aborted because it's very difficult to recover from orthodontically. Um, in those cases, probably would have to go back and do some sort of surgical augmentation on the side that didn't expand. In our practice, we see the patients as they go through the expansion once a week because that's exactly what we want to catch early on.
Hmm.
Um, we want to get the aesthetic and the airway benefits, but we still want to be able to finish the case when we're done too, make sure that the teeth can come together.
So for a patient who starts out in a class one, right, and then you start monitoring their expansion, and by the way, class one for the audience just means that the upper and the lower are pretty much even and they're in a good relationship to start. Um, and so you're monitoring the MSE expansion and you start seeing the left side creep out more than the right side. And then you go another week and now you see a 0.5 millimeter of crossbite on the left, but the right side is right where it started. That's a red flag to you.
It is, because and so we'll often take an x-ray, and sometimes we've seen that the tad maybe inadvertently got caught in the suture on one side, so the other side is splitting and this side is anchored. And if that's the case, maybe we can recapture it by redoing the tads. But if the split ever started on one side and not on the other, then we're sort of in a tricky situation.
Yeah, orthodontically to fix that.
Yeah.
Well, that sort of wraps up the specific questions that I had for you. But I do want to give you the opportunity if there's anything new you're working on or anything else from your slideshow you want to show. I mean, my audience is pretty much interested in all of this stuff and they are hungry for content. So please feel free to show us anything more.
Well, this is maybe a topic for a whole nother discussion, but there's this idea of the importance of getting the lips to come together. So talk about facial growth and development. If for example mouth breathing led to a small lower jaw and the jaw drops down and back, a lot of the patients we see, they struggle to get their lips to come together. And patients come up with all sorts of ways to position their lower jaw and or position their neck to get their together better, and they end up with cervical pain, headaches, TMJ pain, etc., just to get their lips to come together. So whether they sit like this or tense these muscles. And so for those patients, surgery becomes really powerful because it moves the chin button. So I am a lot of the surgeons that understand this harmony are going to recommend two jaw surgery to correct these cases. And I think the layperson hears two jaw surgery and thinks that it's too aggressive. But if we want the right outcome, we have to think about two jaw surgery. So I can show you what that looks like.
Please do.
So if we look at this woman, I'll point out some things that I'm looking at. We see a longer lower facial third. So that means from where the nose meets the lip to the base of the chin. We see that the chin is down and back relative to the profile, the forehead. And we see that there's a gumminess to the smile. There's some lip strain to keep her lips together as well. And we can see that longer lower facial third, and then that chin is behind that white line. And if we think about the plan, if we think about these reference lines, we want to get the center of the central incisor to touch that line. Does that make sense there?
Mm-hmm. You mean
And
like when
so,
you're planning a surgery, the goal is to get that tooth that far forward?
yeah, so if we look here, we want it here.
Mm-hmm. Mm-hmm.
That's going to support the upper lip, that's going to support airway. So we have to move that jaw here. Now we can move this jaw here. And that's why we need two jaw surgery. And if we look at that, we can't lower jaw far enough if we don't move the upper jaw. And you notice too, the chin swings in a counterclockwise direction.
Mm-hmm.
And that's how we get a more square jaw.
Right. Right.
And so she's a lot less gummy, and you can kind of see the change profile.
Mm-hmm.
And that's why two jaw surgery is important. It's because it has to do with the upper teeth. Now she can get her lip together much more easily.
Totally. Totally. Um, so it's obvious that two jaw surgery or double jaw surgery or MMA um, is very effective and achieves great results. Uh, do you, do you think there's really no shortcut around that? What do you think about face mask? What do you think about reverse pull headgear? You've ruled out SFOT as a way of accomplishing this counterclockwise forward movement. What about face mask?
Face will do it for the maxilla, but it can't get the mandible forward. Mandibular growth is a whole nother topic. So in a
Totally.
maxillary deficient patient with a healthy mandible, we can get the maxilla forward, especially in a younger patient.
Mhm.
We can't get the mandible to grow, especially after puberty. You can in a little kid, maybe. That's a whole nother talk.
Totally, totally. And I'd be very interested to have that talk. But so you don't think that mandibles are usually fine and full size, but it's just that the maxilla has them trapped back, and if you can move the maxilla forward, then the lower jaw repositions itself and and reveals its full size. You actually think that both jaws underdeveloped together?
Oh, for sure, especially if you have a breathing disorder at a young age. So there's the ramus height, there's condylar growth and growth right here. And so any one of those parts of the mandible can be deficient. If you have a short ramus height and you get the maxilla forward, you're still going to have a deficient lower jaw. You can't grow this bone, and you can't grow this bone just by moving the maxilla forward. And
Mhm.
mandibular growth takes years. Um, we start these kiddos young, early, trying to get the mandible to come forward, but it's not a quick process.
Mhm. Mhm. Yeah. And for those with reservations about double jaw surgery, what do you tell them when they complain to you about, oh, I'm afraid of permanent numbness, and I'm afraid of my jaws being weaker and flimsier for the rest of my life? And um, uh, how do you talk to patients about going into something like that?
I think numbness is that is a true concern. And I think talking with your oral surgeon, your particular risks is really important. Younger people have a lower risk than older people, but it is a true, real risk. And it depends on everybody's anatomy and health. Um, I don't know that I don't know where the flimsy or weak jaw would come from. With today's fixed plates, we see great healing. We see very few complications. But I think anybody that's trying to weigh the pros and cons needs to meet with an oral surgeon to find out what their particular need, find out particular risks are. And before you have that consultation, you just don't know.
Hmm. Hmm. Great. Yeah. So what I'm hearing from you is that the ultimate package, the ultimate treatment plan for uh, taking someone with a super underdeveloped face in every dimension, which is very common, the ultimate plan would be something like, and of course it's going to be individualized to the patient, but something like MSE plus two jaw surgery will get you the ultimate amount of gains.
So that's the protocol Stanley Liu does at Stanford. He and his team with Yoon, who's the orthodontist on the team, they do dome and then they do MMA.
Mhm.
There's other surgeons that we work with that do maxillary expansion at the of surgery. So it depends on your team. I think the take home message for the audience is to find your team. Make sure it's a team that has done many cases like this, that understands aesthetics, airway, and function, and how it all works together in a system. And I think asking really good questions is going to be key to making sure that you understand that the team is the right team for you.
Totally. It's just so hard to find a team. It's hard to find an individual. It's hard to find an airway focused orthodontist, never mind one who works closely with a periodontist and a surgeon and, you know, an ENT and a myofunctional therapist. It's so hard to find a bunch of them who already talk to each other. Getting them to
I,
try to talk is like trying to herd cats. And
well, I think that's why Dr. built the circle, because he heard that over and over and over, and it's brand new, so it's still being built. Practitioners are signing up every day, but that's the hope and goal. That was his dream and his vision, because we're all hearing what you're saying. I'm lucky I have my team here, and I know them, I trust them, I know that I can refer a patient to them, and we're speaking the same language. But
so that website is not just for people who do tongue tie releases, it's for the whole airway focused, face focused world of providers.
yeah, that's his goal.
Great, great. That's
Yeah,
awesome. And again, there'll be a link to that in the description below.
yeah.
All right. Well, um, if there's anything else you'd like to share, otherwise we can wrap up.
I think it's great. I think just making sure that your audience keep asking questions. You asked great questions. I think we all are trying to learn. We're all on this journey together, and what we talked about today, maybe in another 5 years, we'll look at things even differently. So
Mhm.
it's exciting. We're all on this journey together.
Absolutely, absolutely. And if there's one thing you can rest assured of, it is that my audience will keep asking questions and keep talking about this stuff in their underground online forums and stuff. There's a ton of very interesting conversations happening out there, and I try to bring in real doctors like you to put light on these subjects because there's a lot of misinformation out there, but you've provided us with a ton of good information today, and we appreciated having you on. So, Dr. Bockow, thank you so much, and keep doing the great work you do. And by the way, I will be putting all your links in the description below. So if someone wants to contact you or become your patient, all they've got to do is go down to the description and they can reach out to you at your practice.
Well, thank you. Thank you. Well, good luck to you and your journey too.
Thanks. And by the way, do you do remote consultations in case someone is interested in speaking to you from far away?
We do. There's a link on our site. If you look, it says virtual consult.
Fantastic. All right. Well, thank you so much, and we'll talk to you again in the future, perhaps.
Great. Thank you. Thanks again.